Good afternoon to you all. Today I'm going to present the outcome of uncut Roux-en-Y procedure after radical gastrectomy in gastric cancer surgery. So the background, we know that gastric cancer is one of the most common malignant tumors of the gastrointestinal tract, and according to GloboCan data in 2022, it is ranked in the top 5 cancers in worldwide. In Bangladesh also, it is, though we don't have the specific statistics in our country, but according to GloboCan, it is within the top 10 cancers. But in our clinical practice, we find more gastric cancers than shown here in the GloboCan data. We know the treatment options, radical surgical resection, neoadjuvant, adjuvant chemo, radiotherapy, molecular targeted therapy. So regarding post-gastrectomy reconstruction, there are a few options like Bilroth-1, where we do connect the duodenum to the stomach. But it has some physiological advantage, but greater anastomotic tension and greater risk of anastomotic fistula. Bilroth-2, where we connect the duodenum to stomach, it solves the problem of anastomotic tension, but it increases the incidence of postoperative alkaline reflux gastritis, esophagitis, and anastomotic ulcers. Then comes the Roux-en-Y construction. It addresses the problem of alkaline bile reflux, solves the problem of anastomosis, but the Roux-stasis syndrome still prevails. Then the modified version, uncut Roux-en-Y anastomosis, was invented. The type of study was prospective, all-inclusive, who gave consent. Different hospitals of Dhaka was the study place. Patient having early and locally advanced gastric adenocarcinoma, both primary and post-NSCT cases were included. Patient not having a gastric resection or patient having palliative procedures only were excluded. Sample size was 44 patients. So regarding the vasculature and the lymphatics, we know that stomach has a very good vasculature. Left gastric and the common hepatic artery tributaries, right gastric, splenic, so many artery and tributaries are there. Regarding the decision, it is solely dependent on the MDT. We talk for all the cancers with our oncological colleagues regarding the decision, and we take the decision to operate. And the diagnosis depends on the endoscopy by the surgeon, biopsy and assessment of the extent, which is the staging. We follow the AJCC staging guidelines and the NCCN guidelines. Proximal gastric cancers usually treated by SWOT classification, that is type 1, type 2, and type 3. And for type 1 and type 2, we treat it as esophageal cancer, and type 3 as pure gastric cancer. The resectability, or when we do not operate for cure, this is a locally regionally advanced disease, infiltration to the root of the mesentery or parotid lymph nodes, invasion or encasement of major vascular structures or distant mets or peritoneal seedlings. So surgery as primary therapy is appropriate for less than equal to T1B cancer or actively bleeding cancer, or when postoperative therapy is preferred. So we do distal gastrectomy, subtotal gastrectomy, or total gastrectomy are the options. So gastric resection should include the regional lymphatics like perigastric lymph nodes or D1, or those along the named vessels of the celiac axis, or D2. The goal is the examining at least 16 or greater lymph nodes, because according to NCCN guideline, N3 mets in 16 or more regional lymph nodes. So at least 16 lymph nodes should be examined. So this is the D1 resection, where we entails the gastrectomy and the resection of both the greater and lesser omenta. And D2 dissection, D1 plus all the nodes along the left gastric artery, common hepatic, celiac artery, and splenic artery. Why this is so important? Because postoperative chemotherapy plus chemoradiation is required, patients who receive less than D2 lymph node dissection. So this is a D2 lymphadenectomy we are doing. These are nodes along the common hepatic artery, and the common hepatic artery is just below the lymph node. We are separating it with harmonic scalpel. You see all the blood vessels are there. This is the common hepatic artery. After removal of the lymph node, this is the gastroduodenal artery. So after removal all the lymph nodes, this is the left gastric tight, then the splenic artery, common hepatic, and then the gastroduodenal artery. This is the celiac trunk. And this is a specimen. So this is a specimen of lower radical gastrectomy, and here we, after doing the blood vessel, you can see all the lymph nodes in the station 135, station 11P, station 7, 8, and 9, station 6, 4D. This is another specimen. So here you see the gastrojejunostomy and jejunostomy. I'll discuss it later. So now, uncut Roux-en-Y gastrojejunostomy. It is invented by Van Stigman and Goff in 1988. This method does not cut off the jejunum, maintains the continuity of proximal jejunal anatomy and electrophysiological activity, avoids secondary pacemaker in the intestine, and helps relieve RSS symptoms. So this is the technique of uncut Roux-en-Y reconstruction. So we do first the distal gastrectomy, and you see the plan line of incision. Then we do the end to side gastrojejunostomy, about 25 to 35 centimeter distal to ligament of Treats. Then we do a side to side jejunostomy, approximately 10 to 20 centimeter distal to the ligament of Treats and 20 to 30 centimeter distal to the gastrojejunostomy site. And finally, the jejunal lumen is occluded at a site 5 centimeter proximal to gastrojejunostomy. So this is an uncut Roux-en-Y esophagojejunostomy after a total gastrectomy procedure. And you can see the esophagojejunostomy site at the top, and the efferent limb, the afferent limb, this is the jejunostomy site, and this is the afferent limb closed with the proline. And this is the drawing. So our modification is uncut Roux-en-Y. We put nasojejunal tube for all the patients, feeding jejunostomy in some cases, early mobilization, oral feeding as soon as bowel sound found, and removal of NG tube as soon as possible. Our results, mean age was 56.5 here, male is to female, 38 is to 11, 14 patients had comorbidity, 38% patient had proximal tumor, 62% distal. 6 cases were early cases, 38 cases were locally advanced, and 5 were advanced cases. 53% patient got neoadjuvant chemotherapy. We did 58% patient had a diagnostic lab prior to surgery. Type of surgery, lower radical gastrectomy 25, total radical gastrectomy 17, feeding jejunostomy only for 3, upper radical gastrectomy 2, and others were 2. Gastric reconstruction, uncut Roux-en-Y was 39, and 5 were Roux-en-Y resection, well, R0 resection in 40 cases, R1 resection in 1 case, and R2 resection in 3 cases. 4 patients had multivisceral resections, and the postoperative ward stay was, mean stay was 11 hours. A bowel sound appeared, mean hours were 51.33, NG tube removal mean time were 83 hours, and we took these 44 cases. Liquid started for 54 hours, semi-solid started in 78 hours, and mean hospital stay were 10 days. Few patients had delayed gastric emptying, anastomotic leakage were in 2 patients. The management was secondary suturing for infection in 2 cases and re-laparotomy for 2 cases. So in conclusion, we can say that uncut Roux-en-Y reconstruction after radical gastrectomies for gastric cancer was secure and feasible. Uncut Roux-en-Y reconstruction have some advantages like lowered incidence of reflux gastritis or esophagitis, delayed gastric emptying, and Rho-stasis syndrome. but high-quality RCTs in multiple centers are still needed for further confirmation. Thanks for your patient hearing.